Today I'm going to discuss on pedigree analysis and pattern of inheritance. I have clubbed these two topics together because without understanding the pattern of inheritance, you cannot analyze the pedigree. So you need to understand what are the various types of inheritance in genetics. And if you can understand that, then your pedigree analysis will be easier for you. So, okay. So we all know this person. He is a Gregor Mendel. So Mendel is called as father of genetics. So Mendelian inheritance and heredity, it goes hand in hand. And we all know his famous experiments with these pea plants. So pass the peas, like we used to say. So he has described various modes of inheritance, and it's now well established fact that how the inheritance happens. So we need to remember this person at this point of time when we start our discussion on pattern of inheritance or mode of inheritance and pedigree analysis. So in genetics, there are few terminology we need to understand. If you can understand this, then it will be easier for you to move forward. Number one, there is something called as genome. What is genome? Genome is complete complement of an organism's DNA. So whatever DNA you have in a single cell, it may be in the nucleus, it may be in the mitochondria. So the complete together is called as the genome. So in the cellular, in the cell, the DNA is organized in the form of chromosomes. Chromosomes are nothing but tightly coiled double-stranded DNA. And genes are a specific portion of this chromosome, which codes for the protein. And even in the gene, there are two components. One is exon, another one is intron. Exons are that part of the gene which is coding for a protein, whereas intron are the part of the gene which is in between two exons. They are more of a regulatory in nature. So usually the protein is coded by the sequence which are present in the exons. So we need to understand these three things: genome, chromosome, genes, exons, and introns. So then we need to understand what are the different laws of inheritance. That is called Mendel's law of inheritance. The first law is law of dominance. So an organism with alternate form of a gene will express the form that is dominant. For example, an organism has got two types of genes, one for tall stature, another one for short stature. So when this organism is heterozygote for this particular phenotype, then the dominant form, that is tall form, will express. So there is an alternate form that dominant will express. So we need to understand. Then there is something called as law of segregation. During the formation of gametes, the two alleles means two copies of genes, okay, which is responsible for a trait separate from each other. So that is your meiosis. So these alleles for a trait are then recombined after fertilization. That means a haploid from the either of the parent, they recombine at the fertilization and produce the genotype for the trait of the offspring. This is called law of segregation. So during gamete formation, they separate independent of each other. Now, law of independent assortment is alleles for different traits are distributed to sex cells independently of one another. So it doesn't, that's why we always say, whenever we estimate a recurrence risk, it's always for that particular pregnancy. With every pregnancy, the risk remains the same because these different traits distribute to the sex cells or gametes independently of one another. It doesn't have any memory. Last time there was some sort of like, for example, if one child is affected with their autosomal recessive disorder in a family, it doesn't mean, when we say autosomal recessive disorder, the recurrence risk is 1 in 4. So the 1 is over, another 3 will be normal. That doesn't happen because of this law of independent assortment. Because it independently distributed into the gametes, so every time there is a risk of having a child with affected that particular disorder. So these are three laws of Mendel's law of inheritance. Why we need to understand is when we say inheritance, there is something called as Mendelian inheritance. There is something called as non-Mendelian inheritance. When we say non-Mendelian inheritance, in non-Mendelian inheritance, it will not agree with one of these laws. So that's why you call non-Mendelian inheritance, that we are going to discuss in subsequent slides. Now, when it comes to genetic disorder, basically we have three types of disorder. Two most common, that is chromosomal disorder. Another one is single gene disorder. And there are some others called, now recently this has been well established, mitochondrial, due to mutation in the mitochondrial DNA, and imprinting disorders. So I'm going to discuss that also later. Now, chromosomal disorder means the abnormality with respect to the number of chromosomes, or a numerical abnormality of the chromosomes. That means instead of 46 number of chromosomes, there may be one extra, one less, and the whole set of chromosome is duplicated, that is triploidy. So these are numerical abnormality of chromosome, or structural abnormality of the chromosome, where there is something called as translocation of chromosome, or there is a deletion of chromosome, or a intra-chromosomal deletion, or intra-chromosomal duplication. So these are some of the chromosomal disorder. That is not the subject of discussion for today's topic. So today's topic, we are focusing on single gene disorders and other types. Single gene disorder means there is a defect or abnormality in a single gene, the sequence of a single gene, and these are inheritable. So that's why we have to look at the pattern of inheritance when it comes to a single gene disorder. So single gene disorders are some medical conditions which are caused by change in just one or both copies of a particular pair of genes. So these are called as single gene disorders. And the three common types of single gene disorders are autosomal dominant, autosomal recessive, and X-linked. And even Y-linked is there. But these are most common types. Before we go into the details, I'm just giving you one analogy of how the mutations works. And these are some of the questions. I was told that there are some undergraduate students. This will be helpful for your NEET exams and other things. So a single gene disorder, the mutation in a single gene. See, gene usually it's a script for the protein construct. So there is a blueprint for the protein construct. How does a blueprint read? There is a script in that. For example, a normal gene may read like this. During this lecture or during the lecture, people slept until the end, because we all know genetics is so boring that we always sleep. Even when the genetic portion of chapter comes in our textbook, we usually skip. It's a part where it usually induces sleep. So the script is, during the lecture, people slept until the end. So there is something called as missense mutation. So here in the slept, instead of L, there is a W. So L is replaced by W. So how does it read? During the lecture, the people slept until the end. The lecture was so interesting. So everybody was swept under the, they really liked that and they swept until the end. There is something called as nonsense mutation or a stop codon mutation. Here, during the lecture, then there is a full stop. Instead of L, there is a full stop. There is nothing beyond that. So that means there is the change which results in a nonsense codon will lead to nonsense mutation. So that means you will have a protein which is truncated protein. Then there is something called as a deletion, intragenic deletion. Okay. So here, during this lecture, the people is now deleted. So during the lecture, slept until the end. We don't know who. So your protein will read like this. There is something called as insertion. So here there is quietly inserted. So during the lecture, people slept quietly until the end. And that's very true when we are doing online classes. We don't even know what's happening at the other end. At least in a live lecture, I can able to see who is sleeping, who is alert. But here we can't do that. So it is an insertion. Similarly, there is something called a frame shift. So during the lecture, people, we don't know. This is very nonsense. We can't understand this. So the whole frame will be shifted there. We all know that the codon, three letter will lead to one codon. So if there is a change in that codon, the whole frame will shift. And there is a new class of genetic variation that's called epigenetic variation. Here, the script remains same. During the lecture, people slept until the end. But after a heavy lunch, if you have a post-lunch session, people will sleep. Not because of the change in the script, because of the external factor called heavy lunch. So in epigenetic modification, the nucleotide sequence or the codon sequence is unaltered. There is some external effort which makes the whole gene silent. That's due through your methylation or histone activation. There are various types. So we are going to discuss that in subsequent slides. So these are the common mutations what we see in single gene disorders. I think I'm clear now. Now the actual core of the discussion today, that is pedigree. What is pedigree analysis and inheritance? Okay. There are some ground rules for pedigree. Okay. So for a clinical pedigree, that means where you are not intending to publish this pedigree. In that scenario, we have to have these things in that pedigree chart. One is name of the proband, that is the index patient, or the consultant. Consultant means the person who has come for genetic counseling. He may not be the proband. Somebody else in the family is affected, he has come for a genetic counseling. Okay. For others, you need to have family names or initials as appropriate for identification. And you should also register the name and title of person who is recording a pedigree. For example, if I am recording a pedigree, I have to write my name and my designation and then the date. And historian, who is giving the information, is it reliable or not reliable? We all know about this. And reason for taking pedigree. Why the pedigree we are taking? What is the chief complaint there? Why they have come to you for a consultation? Maybe an abnormal prenatal ultrasound or a familial cancer or a developmental delay or dysmorphic something which has pushed the patient to come to you. We need to write that. Then ancestry on both sides of the family, father side and mother side. And we need to follow this principle, order of information placed below the symbol or to lower right. One is age. Or you can write, ideally you should write the date of the birth. Because the age as on today may be different when we are reviewing this case, sequentially maybe down the line, age may change. So better to write the date of birth. Or if there is a death, you should write the date of death also. And evaluation, what are the evaluation you have done? Echocardiography, ophthalmic examination, karyotype, we need to write next. And then pedigree number. So the Roman numbers are for generation and the alpha numerical number is for ship. Okay. And we need to limit identifying information to maintain confidentiality and privacy. This is very important when you want to publish these pedigrees. I mean, there are in the genetic papers, we have to, many a times we actually publish the pedigree. So we need to keep in mind when we are doing that, you need to be confidential and you should respect and protect the privacy of the patients. Now, very important is symbols. Okay. So we all know these symbols. I don't know, wait just a sec. I will use the pointer. Okay. Is my pointer visible? Can somebody raise your hand or something?
Yes, sir.
Okay. So this is a square. Square is male. A circle is a female. Okay. And a diamond. Diamond is, we don't know. We don't know the sex of the child. It may be unborn child or a child with a ambiguous genitalia where we don't know the sex of the child. So in that scenario, we have to mark it as a diamond. Now, when you shade equally, that means this person has got a particular condition or affected person, maybe male, female. Or if you are shading partially, that means if a person is having more than one condition, can happen. more than one condition. Say, for example, if a child has got a Down syndrome, child may also have a polydactyly, and father may also have a polydactyly. So this child is having autosomal dominant polydactyly and Down syndrome. Then we need to shade in two different color or different pattern, and you can consistently use the same pattern across the pedigree. Now sometimes we write the number inside these symbols. That means this number may, suppose for example, if we are taking the pedigree and we have to look at the ship of the father. Father has got 5 brothers. Then you just write the 5 numbers. If all of them are normal, if all of them are okay, if they don't have anything to contribute to that pedigree, you can just write 5 inside that symbol. So this is multiple individuals, then you know the number. Suppose if you don't know the number and you know that they are okay and there is nothing to contribute, you can write just N. N means you don't know the number, or you can write a question mark inside that. Now, if that person is deceased, then you have to strike a diagonal line across the symbol. Okay, and you should write the date, death, D for death. This is D for death. This is B for birth, dot, and the age or date or year of death. You can write that. I think this is very easy. We all would have been used in our daily history taking and daily case sheet writing. This is very simple. I know where the problem comes in DNB ASCII. So now, suppose if the person who is seeking the genetic counseling is unaffected, you have to mark an arrow, but it will not be shaded. So he is the consultant. If the proband, then you need to mark with the affected person who is shaded, and you have to mark with an arrow. Okay. So then, if there is a stillbirth, okay, you have to write SB, and below that gestational week. If you know the sex of the baby, you can mark either as a square or a circle, or if you don't know the thing, you can write a diamond and you can strike it off, and you have to write SB. SB is stillbirth. Or if the pregnancy, if there is an ongoing pregnancy, in our country we don't know the sex of the baby, we usually write as a diagonal, and inside we write P, and down we write the gestational age or LMP, last menstrual period. If the karyotyping is been done to the fetus, then we'll write the karyotype. Usually when we do a fetal karyotype, we don't give the sex chromosome. So we usually say normal sex chromosome and the number. Or if there is an altered, like 47 plus 21 normal chromosome, like that. And if you know the sex in Western countries, they will know the sex before birth. So you can appropriately mark that side. Now there are 3 scenarios during pregnancy. One is spontaneous abortion, that is marked as a SAB, spontaneous abortion, or sometimes there will be termination of pregnancy, TOP, or ectopic pregnancy, that is ECT. So a triangle is abortion. Okay, you can shade or you can leave it like that. If you shade, that will be you can shade and you can leave it like that. And then it is called spontaneous. You have to write SAB, spontaneous abortion, and you should write the number of weeks. Gestational age, at what gestational age the spontaneous abortion has happened. Suppose if you strike that spontaneous abortion, that will lead to that will indicate TOP, that is termination of pregnancy. Better you should write, if there is a termination of pregnancy, you should write the gestational age as well as the reason for termination of pregnancy. It may be social reason or it may be medical reason. You need to write that. So and you have to write TOP. If you write ECT, then it indicates ectopic pregnancy. I think. Is it clear now? Now, the next important step in pedigree writing is the relationship lines. So there are 4 lines which we usually see in a pedigree. So this line, the number line 1 is relationship line. This line is called as relationship line. This is a horizontal line between 2 individuals. So these 2 are married. Okay, and the vertical line is called line of descent. Okay, and another horizontal line below this vertical line, but not connecting to directly into two individual is called as ship line. And another vertical line which is coming from the ship line is called as individuals line. So relationship line, line of descent, ship line, and line of individual line. So some convention is you should, if possible, I'm talking, male partner should be to the left of female partner on the relationship line. Sometimes it may not be possible, but most of the time it is possible. And siblings should be listed from left to right in the birth order. Conventionally, it indicates whoever is been written as a first one, he is the oldest, and the last one is the youngest. So this is the convention. Now, let's come to relationship line. Okay. If there is a break in the relationship line, like this, that means this relationship no longer exists. It may be divorce, separation, whatever it may be. So if there is a two lines, then it indicates consanguinity. So remember one thing, whenever we are writing whenever we are taking a pedigree and there is a consanguinity, make sure that you should be able to establish how this consanguinity has come into the picture. That means there must be somewhere relationship. Suppose if there is an uncle-niece marriage, that means this person, the husband, is uncle for the wife. That means wife's mother's brother or something like that. So there you should establish that relationship that should be reflected in your pedigree. So consanguinity is marked by two lines, and if you can able to establish the degree of consanguinity, you should please mark the degree of consanguinity above this line. And there is a chart to establish the degree of consanguinity that is available online. You can download that. No need to remember that. Unless you have the chart, it's very difficult to exactly say the degree of consanguinity. Though we say uncle niece is third degree, no, it's not third degree. Actually, it goes to sixth degree. So you can able to see that there is a chart available online. Now, when it comes to line of descent, so we all know this is a male and a female, the line of descent, and this is the female child, this is a daughter. Okay. If there is a monozygotic twin, you know this is a you are 100% sure it's a monozygotic twin, then we need to draw a horizontal line between these two slanted lines. Okay. If dizygotic twins, then this connection is not, it should not be written. If it is unknown, you can write a query. This is trizygotic twins. Or if you don't know the parents, then you should just write a line of descent and a question mark. Now, if the family is completed, then we should write, or if there is no children, you should write a horizontal line after the line of descent. If vasectomy is done, then you should write inverted T below the husband and inverted T below the wife if it is a tubal contraception, permanent contraception. If there is an infertility, then we should always write two horizontal lines below the line of descent. If this is due to azoospermia in the husband, it's two lines below the line of descent below the husband. If it is due to some causes in the female, endometriosis or something, then it's below the circle. Now, this is something very important. I had seen many a times it's been asked in your ASCII. How do you make out adoption? Okay. Remember, whenever there is a break in the line, then that is not a natural relationship. Okay. For example, here in the extreme left, so we have one pedigree. Whenever a individual is marked within a bracket, that means he is adopted. We don't know whether he is adopted in or he is adopted out. So if there is an individual who is marked with a bracket and the line of descent in the is a broken line, then it is called as adopted in. That means these two parents, these parents are not the natural parents of this individual. You understand? So since they are not natural, they have adopted this child. That's first thing. Suppose if there is unbroken line and marked in the bracket, then that means this person is adopted outside this family. This parent or the natural parent of this individual, but he is adopted out. Now, if you know where he is adopted, you can see that he is adopted to the sister of the mother. So this mother has adopted this child. There is a broken line. So brackets are used for all adoptions. Adoptive and biological parents are denoted by dashed and a solid line of descent respectively. That means adoptive parents are denoted by dashed line of descent, whereas the natural or biological parents are denoted by solid line of descent. Clear? Now, these are new scenarios what we are seeing, and we are going to see these scenarios very frequently in future. So you need to understand this. So the pedigree A, here we are talking about the donor. Suppose in this family, okay, there is an ongoing pregnancy in the wife, where wife is naturally giving the ovum, where the sperm is donated by a different person. So a sperm donor, and this is the pregnancy. If this pregnancy if the couple is known infertile, then we need to draw these two horizontal line below the line of descent. Okay, this is sperm donor. Similarly, ovum donor, and the sperm will be donated by the father, and this ongoing pregnancy is in the wife. So then you have to write in the middle of the this relationship line. Okay, this line of descent comes from the middle of the relationship line, and the sperm is and the ovum is donated by a third person. Suppose we are talking about surrogate here. Okay, so here surrogate is a third person. Here the pregnancy is a product of conception of the sperm and the ovum of the parents, but the surrogate pregnancy is happening in a third person. So this is called surrogacy. Now, surrogacy can also happen with a donor ovum and the sperm of the couple, or if the donor can be a related donor and related surrogate mother also, or surrogacy, or this is a planned adoption. Surrogate mother with a donor sperm, and this pregnancy is planned to be adopted by this couple. So this couple will adopt this child. That's why there is a broken line of descent, and this is in a bracket, and these two are the natural biological donors. You can't call them as couple or a parents. They are donors, sperm donor and the ovum donor. So this is slightly complicated, but these are the scenarios what we are often nowadays seeing quite often in our clinical practice. So you need to know this. And this is there in our Nelson. So there is a high chances that these scenarios may also be given to you in your ASCII. Now, the next question is, when you have understood these symbols, now next question is, how do you evaluate a pedigree? So when you are evaluating pedigree, there are three questions you need to keep that in your mind. One is transmission, what are the sex differences, and how it is segregating. So whenever you see a pedigree, you please ask yourself these three questions. Are there affected family members in every generation? That means there is a vertical pattern of transmission. Or the affected family members in only a single generation. That is your horizontal pattern. That means, is there a vertical transmission or a horizontal transmission? This is the first question. Next is, what is the ratio of affected males and females? Are there male and females are affected? Okay. Then, is disease or gene being passed through unaffected female? Is there any male to male transmission? what percentage of children are affected? All sons but none daughters. So this is segregation. So please, whenever I'm going to discuss, I'm going to show you so many pedigrees, and we are going to take up these questions again and again, and we are going to answer that. So this is how we have to evaluate a pedigree. What is the transmission? Vertical or horizontal? Males and females are equally affected. Is it passed through an unaffected female? Is there male-to-male transmission? And what is the percentage of children affected? All sons, none of the daughters, or all daughters? What is that? Okay. Now, pattern of inheritance. We have two types of inheritance: Mendelian inheritance, non-Mendelian inheritance. In Mendelian inheritance, autosomal dominant, recessive, X-linked recessive, X-linked dominant, and Y-linked disorders. There is non-Mendelian inheritance, digenic inheritance, mitochondrial or matrilinear inheritance, tri-repeat sequencing, imprinting disorder. In imprinting also, we see that uniparental disome. So these are non-Mendelian inheritance. They don't follow Mendel. They are outcast from the Mendel. So they are called non-Mendelian inheritance. So non-Mendelian inheritance, this is due to, it may be due to two, there are two different types of this non-Mendelian inheritance. So two different types of complications we can say. For example, there are in some scenarios where your genotype follows Mendel's law, but phenotype do not follow them. Okay, because somehow the underlying genotype ratios are hidden. So this can also happen in a regular Mendelian inheritance that we are discussing now. Suppose in autosomal dominant, because of some reason, there is a discrepancy between genotype and phenotype. So genotypes, when you look at, definitely they have Mendel's inheritance, Mendelian inheritance pattern. They follow the Mendel's law. But when you look at phenotype, they don't. Whereas in some scenarios where Mendel's law do not apply, here both genotype and phenotype are not following Mendel's law. These are your non-Mendelian inheritance. Digenic, mitochondrial, matrilinear, all these, that doesn't follow Mendel's inheritance. Okay, Mendel's law of inheritance. Now, so I said the first one, genotypic ratio, genotype will follow Mendel's law, but phenotype do not. That's because of these factors: non-penetrance, new mutations, adult onset conditions, consanguinity, interactions, sex-limited and sex-influenced disorders, germline mosaicism, anticipation, heterogeneity, and pleiotropism. So these are the factors which will mask the phenotype. Underlying genotype is Mendelian, but the phenotype is non-Mendelian. Now, look at this pedigree. This is from your Nelson. For your familiarity, I have picked up from Nelson. So if you go back and look at your Nelson chapter on pedigree analysis, it will be easier for you to understand. Look at this pedigree. I said three questions you need to ask. One is transmission, sex difference, and segregation. Now look at this. What is the type of transmission here? All generations are affected. That means multiple generations affected. So there is a vertical transmission. Okay. Males and females are all affected. Okay. And there is male to male transmission. You can see from Roman 1:1:2:5, there is a transmission, male to male transmission. There is also male to female transmission, female to male transmission, female to female transmission. So it's a gender independent transmission and also manifestation. It's not just only males are affected. Even male and female are also affected. So male and female are equally affected, and there is a male to male transmission. So this is the feature of, these are the features of autosomal dominant inheritance. So in this inheritance, the next question usually they will ask, what is the recurrence risk? So 50% recurrence risk in the subsequent pregnancy. So every affected child has an affected parent except in de novo mutation. If the mutation is de novo and if parents are unaffected, then it's likely that it started in the child, and this, the subsequent the risk in the subsequent pregnancy is 0. Understand? For example, your achondroplasia. Achondroplasia is an autosomal dominant condition with 100% penetrance. That means if a person is carrying a mutation of achondroplasia, okay, he has to be short. There is no question that his shortness is masked. So it has to be expressed in everybody. Suppose if the parent of an achondroplasia child is of normal height, it is not possible for him to carry that mutation. So it's always de novo mutation in such scenario. Okay. Now, there are some complications which are discussed, something called as incomplete penetrance. For example, here, this lady, that is generation 1, second individual, is affected and deceased. She has got a female who is affected, and another daughter, her daughter is affected. Now, how do you explain this? So an individual who inherits the disease, definitely she is an obligate carrier. She has to carry this gene. Otherwise, it's not possible for this 3 to getting this disease. So she has to be obligatory carrier. So an individual, but she is inheriting this gene, but this does not develop the disorder. It's called appears to skip generation. That's called skipping of generation. This is due to incomplete penetrance. This is known with many conditions. For example, Luna. There are so many other conditions where incomplete penetrance is known. Or there may be very subtle clinical features which is completely missed. Another close resemblance, incomplete penetrance, nothing is there. Not even a single manifestation of the disease. Okay. There is something called as variable expressivity. For example, in this family, you look at this. The first generation family has got leash nodule and Kaphilia spot. The second generation, this male child has got neurofibroma, Kaphilia spots, and leash nodule. The female individual has got Kaphilia spot and scoliosis. Whereas this child, granddaughter has got optic glioma, learning disability, neurofibroma, Kaphilia spot. So variable expressivity. So the variability of severity of disorder among individuals with same genotype. Okay, these are seen in most of the autosomal dominant disorder. Neurofibromatosis, Tichercolin. I can give a list of conditions where this is known. So we need to keep that in mind. So for example, if there is only Kaphilia spot, nothing else, it is easily missed. So we have to carefully examine the parent completely before you label the parents as unaffected. Okay. Now there are another two terms you need to understand. One is heterogeneity and pleiotrophy. Locus heterogeneity means different genes are involved in causing the same phenotype. For example, deafness. There are nearly 30 to 40 genes which can cause deafness. Some of them are autosomal dominant, some of them are autosomal recessive, some of them are mitochondrial. There are so many X-linked. For example, and it's also common in practical scenario, a deaf person is likely to marry another deaf partner. It doesn't mean that the child has to be deaf, because the father may be having deafness due to some different gene, and mother may be due to different gene. So the child may be heterozygous for both the gene, may not have deafness. So this is called locus heterogeneity. So different genes involved in causing the same phenotype. Whereas pleiotrophy is something opposite. A single locus responsible for a number of distinct and seemingly unrelated phenotypic effects. For example, Marfan syndrome. So Marfan syndrome, one person, for example, here, the index patient is short, 5'10", dislocated lens, myopia. Whereas his father is tall, mitral valve prolapse, pectus excavatum, no dislocated lens. Similarly, his father has got aortic dilatation, no dislocation, tall stature. Whereas the sister or aunt of this index child has got dislocated lens, myopia, and arachnodactyly and short. So it's a single locus responsible for a number of distinct. One is in the cardia, one is in the eye, one is tall stature, one is in arachnodactyly, pectus, skeletal system. So unrelated phenotypic effect. This is called pleiotrophy. Now there is another interesting scenario. What we see is sex-limited influence and sex limited disorder, sex-influenced disorder. For example, if you look at this whole pedigree, here every generation is affected. That means there is a vertical transmission, number one, and no females are affected here. Only males are affected. Clear? So, and then there is a male-to-male transmission. Okay. And interestingly, there is a female-to-male transmission. Look at this, female-to-male transmission. Okay. Otherwise, this would have been a Y-linked disorder. There is a male-to-male transmission. Every generation is affected. If there was no indication of female-to-male transmission, then it would have been a Y-linked disorder. But there is a female-to-male transmission. So that is an autosomal dominant. Then we need to understand why only males are affected. So this is called as sex-limited disorder. For example, there are some organs that are caused by autosomes, mutation in autosomes. It can occur only in one sex. For example, familial testitoxicosis. This is male-limited precocious puberty. The testes are there only in male, so it manifests only in male. It can be transmitted through female also, because these are autosomal genes. So it can be transmitted through female, but it affects only male. It can also be transmitted through male also. There may be male-to-male transmission, female-to-male transmission also, but it affects only male. So these are called sex-limited disorder. So this gene expression limited to specific sex. So this disorder may appear skip generation. For example, if there is no male affected in this generation, it may skip this generation, but this female carrying that may pass on to her subsequent generation. Okay. There is something called a sex-influenced disorder. For example, gout. Gout is more common in male than female. There may be so many other reasons. It's called sex-linked, sex-influenced disorder. Okay. So autosomal dominant disorder, we need to consider sex-limited and sex-influenced disorders. Now, what are the reasons for dominance? Why this dominance happen? Mechanism of dominance. There are various descriptions or various causes for that. The first is haploinsufficiency or loss of function mutation. For example, because one gene, though we say if there are two genes, one gene is active, another gene is not active, but it's not so practically. So because the decreased production of gene product, because one gene is mutated, can lead to dominance or gain of function mutation, increased gene dosage, or ectopic or temporally altered mRNA production. For example, hereditary persistent HbF, or increased protein activity. It's in periodic paralysis. Dominant negative mutation, especially we see in OI. What happens is in OI is it's a basically collagen disorder. Collagen, we all know, it's a usually the three fibers which coil and form these collagen matrix, and they give the strength. If one of the fiber is abnormal, then the coiling is not adequate. The strength is not adequate. So though it's a negative, this is a recessive, but it acts like a dominant because of this abnormal structure of one fiber. The whole structure is abnormal now. So it's called dominant negative mutation. Similarly, toxic protein alteration. For example, amyloid. Amyloid is a structurally altered protein which get deposited and causes diseases. New protein function. For example, a mutation in alpha-1 AT gene, which is an inhibitor of antithrombin, it can lead to bleeding disorder. And recessive mutation with dominant effect. Like two-hit theory, we all know this retinoblastoma. One mutation is inherited, and the second mutation develops postnatally after some time. Second hit. So two-hit theory, recessive mutation. Though it is a recessive, but it behaves like a dominant effect. Now, this is a typical autosomal recessive pedigree. So go through those three questions: transmission, sex ratio, segregation. So it is only in one generation. So horizontal pattern, single generation is affected. And look at this. There is, gender independent inheritance, and both male and female are affected equally. Okay. So here, parents of affected child are unaffected, obligatory unaffected gene carriers. They have to carry this gene. Okay. And they have the recurrence risk of 1 in 4 or 25%. Unaffected sibling have got 67% chance of being carrier. These are numbers you can calculate, but standard numbers. Okay. Children of affected individuals are obligatory carriers. Suppose if this person marries an unaffected person or non-carrier, then the offspring of this couple will be obligate carriers. Now, there is something called as pseudo dominance. So, if a autosomal recessive disease, if the person who is carrying the autosomal recessive carrier, person is an affected person, there is a 50% chance of their children affected, 50% will be carrier. So the pedigree will resemble like an AD. So vertical transmission, both male and female are affected. So it behaves like an autosomal dominant disorder, but it is not so, because here this affected person is marrying a carrier. So that is masked. This commonly happens in color blindness, where colorblind person can marry a colorblind carrier female, or D6PD can happen with that. So these are common scenarios. Now, in autosomal recessive, only this is X-linked recessive, sorry. So here X-linked recessive, look at this. There is a skipping of generation. Okay, only males are affected. There is no male-to-male transmission. See, there is no male-to-male transmission. Affected male pass genes to all their daughters and none of their sons. No male-to-male transmission. Daughters of carrier females have 50% chance of unaffected carriers. Sons of carrier, that we are going to discuss next. Affected male in the family are related to each other through carrier female, that is Knight's move. So there are some situations where a female can manifest. One is if the female is Turner, that means one X chromosome is absent. There is something called a skewed inactivation of X chromosome. We all know lionization. So in a female, there are 2 X chromosomes. One X chromosome is silenced, but it is random inactivation. It is randomly inactivated. Okay. When there is a random inactivation, if that is skewed towards normal chromosome, for example, more number of normal X chromosomes are inactivated, and the mutant one, more number of mutant are active, or the gene which is the mutant gene containing X chromosome is active, it's called skewed. It is skewed towards normal X chromosome. Inactivation is skewed towards normal X chromosome. In that scenario, a female will manifest because more number of mutated genes are active in that female. So that's why she can manifest. There is something called as X autosomal translocation. So there is a translocation involving X chromosome and another autosomal chromosome. For example, X and chromosome number 14 or X and chromosome number 15. So in that scenario, what happens is, if there are any very important gene at the point of the translocation, so they are dysfunction. They are not non-functional. So in that scenario, the normal inactivation will happen with the normal chromosome because the inactivation apparatus doesn't act on the autosome. So if there is a autosomal translocation, that X will never get inactivated. The another normal X will get inactivated. So always this mutated X derivative chromosome will be active. So that's why these female will manifest. Very rarely there may be homozygous female where she may contain mutation in both X chromosome. So this is called homozygous female. So recurrence risk depends on different scenario. Suppose this is a common scenario. For example, in DMD, mother is a carrier. What will happen? Normal father and the carrier mother. So 50% of the daughters are carrier, 50% of the sons are affected. Clear? Suppose if the father is affected and mother is carrier, so 50% of the daughter are affected, 50% of the sons are affected or normal. another 50% of the daughters are carrier. So 50% of the daughter affected are carrier, 50% of the sons are affected are normal. Affected father and a non-carrier mother. In that scenario, all daughters are carrier, all sons are normal, because father never contributes X chromosomes to the sons. Father will obligatory, has got only one X chromosome, he will definitely pass that on to his daughter. So they will be carrier. Clear? Now, X-linked dominant. Here again, there are two scenarios. If it is a non-lethal variety or lethal variety. So, all generations are affected. There is no male-to-male transmission. Look at this, always female-to-female transmission. Female-to-male transmission, but no male-to-male transmission. So, no father-to-son transmission in this situation. Hemizygosity is not lethal. So affected males pass the gene to all of their daughter who will be affected again. So look at this scenario. Here father is affected. All of his daughters are affected. None of his sons are affected. Similarly, here also, none of his sons are affected. Daughters are affected. Okay. So sons and daughters of the affected females have 50% chance of being affected, similar to the autosomal dominant. Now, the conditions, many a times, this condition is lethal in male. So X-linked dominant with male lethality. So here again, no father to son transmission. So, and all the affected males are deceased. It's lethal. Only female manifest. Okay. The only living male, whoever is living, they are unaffected. Sons and daughters are affected females have 50% chance of being affected, similar to the autosomal dominant. Then Y-linked inheritance. There are a lot of genes in the Y, especially these spermatogenetic genes and all present now. So these are responsible for, the mutation in these genes is responsible for azoospermia. So here only males are affected and it's passed from male to male. Okay. Affected males pass the gene to all their sons and to none of their daughters. So look at this, only males. There is no female to male or female to female transmission, only male to male transmission. Now, the last part of my discussion, non-Mendelian inheritance. The earlier part I have touched upon the non-Mendelian inheritance where the genotypes follow Mendel rules, but phenotypes doesn't follow Mendelian rules due to those pleiotrophy and non-penetrance, variable expressivity. In this part of non-Mendelian inheritance, we are discussing on those disorders, those conditions, those inheritance which doesn't follow Mendelian rules genotypically as well as phenotypically. This is the first example is digenic inheritance. Here, disease alleles, for example, A and B, small a and small b, and they reside on a distinct genetic loci or genes. They are different genes. So for a person to have disease, he needs to be heterozygous of mutant alleles in both the genes. So both genes are required to cause the disease. So these are called as double heterozygotes. You should not confuse this with compound heterozygotes. The compound heterozygotes, the mutations in the two copies of the same gene are different. For example, in beta thalassemia, suppose if both the parents, non-consanguineous parent, if father is a carrier for example, a mutation A in the beta thalassemia gene, whereas mother is a carrier for mutation B in the same beta thalassemia gene, but the child inherits both the mutated gene. One is mutation A and mutation B. In such scenario, that is called as compound heterozygous. Same gene, different mutation, but it's an autosomal recessive. It's a compound heterozygotes. Okay. If the mutation is same in both the gene, that is called homozygous. But here it's a double heterozygote. That means if the gene A, one copy of gene A has got a mutation, another copy is normal, whereas the gene B, one copy of gene B has got a mutation, and the another copy of gene B is normal. So if the person inherits both the affected or mutated gene, even though other copy is normal, it's called a double heterozygote, then they will manifest. The best example for this is your retinitis pigmentosa. So you need two genes and heterozygosity in two genes to manifest this disease. So here both unaffected parents carry a mutation in different genes. So they don't have any disease per se. But their offspring who are double heterozygotes, having inherited both mutations, develop disease. So they exhibit characteristic of both autosomal dominant, that is vertical transmission, as well as autosomal recessive inheritance, 1 in 4 recurrence risk. Now, the next most commonly asked question is mitochondrial inheritance. So this is a mitochondrial DNA, which is circular DNA. Okay, various genes are present in this chromosome, in this mitochondrial genes. They don't follow the Mendel's first law, that is law of dominance. Okay, because there is no pair there. It's a circular gene. There is no another copy. So two alleles segregate randomly during gamete formation. No, it doesn't happen there. So here it is very difficult to distinguish this from autosomal dominant or X-linked. But you should always understand it is transmitted through a female. There is no male to any of the male to male or male to female transmission. It's only from female, but female to male as well as female to female transmission is there. So that is the catching point here. So the only affected female transmit. Both the sexes are affected. We need to understand something called as heteroplasmy and homoplasmy. So let me explain this. In a, say for example, in a particular cell, say you take a muscle fiber cell or a cardiac muscle fiber, cardiac muscle cell. So you will have hundreds or thousands of mitochondria in that particular cell. Some of them may have mutated gene. Some of them may have non-mutated gene. Okay. So if all the genes in that particular cell, so all the gene, all the mitochondria in that particular cell contains mutated gene, then it is called as homoplasmy. Or few of them has got a normal mitochondrial gene, few of them has got a mutated mitochondrial gene, then it's called as heteroplasmy. Now the manifestation will also depends on the degree of heteroplasmy. Suppose if more number of mutant gene carrying mitochondria are there in that particular cell, then it will manifest. So as compared to less number of mutant gene. Similarly, it also depends on the tissue. For example, the cardiac tissue has got highest number of mitochondria. So the chances of having mutant gene is higher in that scenario. So the commonly affected region, commonly affected organs in mitochondrial disorders are your cardia, muscles, CNS. So where mitochondria are more. Whereas some low metabolically inactive tissues like your skin, where your mitochondria are not very highly located, in that scenario, the clinical affections are low. Second point. Third point is there is something called as transmission bottleneck. So when we all know why this happens. I mean, mitochondria is contributed in to the zygote from the mother. The ovum is the only one which carries mitochondria. Sperm doesn't have mitochondria. Okay, that's why it's called matrilinear inheritance. It is transmitted from mother to child. So ovum contains mitochondria. So what happens is when the gamete is formed, the mitochondria are distributed from the oocyte to ovum. So there is something called as bottleneck. It will filter the mitochondria. So it will squeeze the mitochondria. There will be only few mitochondria. So some of them may be mutated, some of them may not be mutated. This is called transmission bottlenecks. Okay, so if they are not, so it depends on the dosage of mutated mitochondria, which is transferred to the child and subsequent replication of the those zygote and fetus and then the child. So the clinical manifestation depends on the transmission bottleneck and heteroplasmy and homoplasmy. So mitochondrial inheritance, when you look at a pedigree, you should always look, most of the time it will be, all the generations will be affected. The most important point is it is unaffected, it is affected female who is transmitting to her offspring, both males and females. Both sexes are affected, and affected female is transmitting, males are not transmitting. So these are the three important points we need to look when we are looking at a mitochondrial inheritance pedigree. Triplet repeat expansion. Here, again, this doesn't follow your Mendelian inheritance. All family members are affected. I mean, vertical transmission is there. Male, female, both are affected. Most important point here is the increasing severity of the disease and early age at onset in subsequent generation is seen here. And it is termed as genetic anticipation. Best example is Fragile X. Number of tri-repeats copies, if that increases over a generation, then the manifestation will appear. So here you can see the first, this is a 55-year-old male who is manifesting. In fact, this pedigree is not a Fragile X. This is an autosomal dominant type. Fragile X, most of the time, males will be affected, females will not be affected. So here it's a defining characteristic of many repeat expansion, but also some autosomal dominant disorders like myotonic dystrophy it can be seen there. This is a typical pedigree of myotonic dystrophy, where the first generation started manifesting at 55 years, came down to 48 to 50 years. Now it is around 40 to 42 years. Subsequently, it will be even younger. So this is called genetic anticipation. The last group of disorder, before I finish, this is important, called imprinting disorder. Most of the time, it is very difficult to write a pedigree here. So usually, this is not an inherited disease, 99%. 2 copies of most autosomal genes are functionally equivalent. This is what the law says. And I have already told you what is epigenetic modification. You remember my last line of my first few slides. That is when during this lecture, most of you slept. The script is not affected, but the whole script has become blurred. Similarly, epigenetic modification is silencing the gene without changing the nucleotide sequence of DNA. This happens through methylation of DNA. That means only one copy of the gene is transcribed to as protein. Another copy is silenced. This is your imprinting. So in imprinting, gene expression depends on the parent of origin of chromosome. Imprinting disorder results from the imbalance of active copies of a given gene, which can occur for several reasons.
यार वो दे जाना यार अभी देगा.
Okay.
दे जाना.
Disturbance there.
Can you mute?
Okay. So the most common example for imprinting disorders are Prader-Willi and Angelman syndrome. So these two distinct disorders are associated with microdeletion of chromosome number 15 at point in the long arm of chromosome number 15, 11212. So this microdeletion, if it happens on a paternally derived chromosome, it will lead to Prader-Willi. If it happens on a maternally derived chromosome, it will become an Angelman syndrome. Sometimes what happens, there is a uniparental disomy. That means in few instances, a child may inherit both the copies of chromosome from the same parent. For example, if child inherits 2 copies of maternal chromosome, number 15, and there is no paternal chromosome 15. That means this child will develop Prader-Willi syndrome. If suppose a child inherits both the copies from the father, then there is no maternal chromosome number 15. So he will develop Angelman syndrome. So these are the reasons for imprinting disorders. Most of the time it is microdeletion of paternally inherited or maternally inherited chromosome. or it may be uniparental disomy. Rarely there is something called as imprinting center. That center is a gene which is responsible for silencing that particular part of the chromosome. If that itself is defective, then it will lead to imprinting disorder. So